we learned about pain, how to assess pain, and also we learned about the management part one. So today, the management part two, that is on opioids. This will be taken by Dr. Amirtha Thambi, who is a palliative care physician and has more than 20 years of experience in palliative care. She is pursuing global fellowship in palliative medicine, and also she is working as a clinical service at Pallium India. So welcome, Dr. Amirtha, and over to you.
Thank you, Shiba, for that kind introduction. Good afternoon, all. Hope I am audible. Can someone confirm? Thank you, Benisha, again. So as Shiva has already introduced, we'll be dealing with the opioids today. I'm not able to put the slideshow. Thank you, Shiva. So we'll be dealing, I understand that you have already gone through the first session on pain regarding the NSAIDs on step 1. So today we'll be dealing with more detailedly with opioids. And in this session, we'll be walking through the following topics: the commonly used opioids, the mechanism of action of opioids, the practical aspects of opioid use, the adverse effects of opioids, and the price of different types of opioids. So this would be a brushing of the WHO analgesic ladder, which you might already be taught in the previous session. So depending upon the severity of the pain, the patients would be prescribed step 1, step 2, and step 3 analgesics. So patients with mild pain would be prescribed with step 1 analgesics, which include non-opioids with or without adjuvants. If the pain is more than mild to moderate pain, step 2 analgesics are prescribed that include opioids for mild to moderate pain with or without non-opioids and with or without adjuvants. So if the pain is more severe, then we go with the step 3 analgesics. So step 3 opioids include opioids for moderate to severe pain with or without non-opioid and with or without adjuvants. So now we'll be moving on to a patient story. Suppose a 56-year-old male who was diagnosed with carcinoma of larynx happened to come to our inpatient unit with severe pain, 10 on 10 pain, which is sharp radiating pain around the neck. And since last 2 weeks, he's unable to sleep due to the severe pain. So I would like to know how we will manage this pain. Can somebody suggest me ways of managing this pain? Those who want to talk can unmute and talk, or else you can type in your chat. So this patient has come to our inpatient unit with severe pain on 10 on 10 pain. Thank you, Jyoti, for that. We can go directly on opioid. Any other suggestions?
Injection tramadol 50 milligram.
Injection tramadol 50 milligram. So as I already said, we have suggesting the ladder, injection morphine from Vaijayanti. Thank you for that. So depending upon the severity of the pain, we will be suggesting which step of the ladder we are going to prescribe on or stick on to. So as it is already described, the pain is 10 on 10. So it is very severe pain. So as Vaidendi has already suggested, we'll be going with the step 3 opioids. So, but it is severe pain and the patient has come to the inpatient unit. So, the ideal way would be going with the intravenous opioid titration, intravenous morphine titration. So now I'll be detailing how we do this intravenous morphine titration. So 1 ampule of morphine, that is 1 ml, contains 15 milligram of morphine. So we'll have to dilute this 1 ml of morphine with 9 ml of distilled water, make it 10 milligram. So that is 1 ml of the diluent will contain 1.5 milligram of morphine. So this 1 ml of morphine will be given to the patient, which contains 1.5 milligram every 10 minutes. So that is injection morphine 1.5 milligram will be given at every 10 minutes interval. And then, so this will be documented. Is there any, do you think there is any issue when we give this morphine? Any sudden issue that can occur when morphine is given intravenously?
Respiratory problem. Arrest.
Sorry?
Respiratory arrest.
Respiratory arrest, drowsiness, respiratory depression,
Pupils can constricted.
pupil constriction. Okay, thank you. Thank you for that.
Hypotension. Hypotension.
Hypotension. Nausea, constipation, okay, vomiting. Thank you for all the responses. Yes, as some of you have already mentioned, the immediate side effect what you can expect is nausea or vomiting. So what do we do then? To manage that, usually before we start with the intravenous morphine titration, we give the patient injection metoclopramide 10 milligram. So an antiemetic is given before the starting with the morphine titration. So once the antiemetic metoclopramide is given, then the morphine titration is started. So 1.5 milligram of morphine is given at every 10 minutes interval. And this will be continued every 10 minutes unless either the pain score gets reduced or the patient has satisfactory pain relief or the patient becomes drowsy, whichever happens first. So that would be the end point for the titration. To explain in detail, so this would be the way you document. Suppose a patient was started on IV morphine titration at 10 a.m. We have started. Initially, we will do the pain assessment and record the pain score. So the patient was having 10 on 10 pain and the patient was not drowsy at that time. So 1 ml of injection morphine, which contains 1.5 milligram of morphine was given. Wait for 10 minutes. Again, record the pain score. So the pain score at 10-10 is 7/10 and the patient is still not drowsy. So repeat 1 ml again and wait for another 10 minutes. So by 10:20, again record the pain score. The pain score is 4 now and the patient is still not drowsy. So we are giving one more dose of morphine, 1 ml is given, which contains 1.5 milligram of morphine. And then wait for another 10 minutes and reassess the patient regarding the pain score. Now the pain score is 1/10. The patient is still not drowsy, but the end point here is that there is satisfactory pain relief at this point. And now we are stopping with the titration. So a total of 4.5 milligram of morphine was given intravenously for this patient to attain satisfactory pain relief. So this patient has come to our inpatient unit, but we want to send him home. How do we send him home? Any suggestions? So we have done the morphine titration. We got this 4.5 milligram of IV morphine, had brought adequate pain relief, satisfactory pain relief for the patient. To send the patient home, what should we do? How can we send the patient home? Yes, oral dose. Thank you. Thank you, Maria, for that. So how do we do that? Yes, tablet form of morphine with laxative and prescription of morphine. Thank you. Thank you, Judy. Thank you so much. Can send them home with a syringe driver. Oral morphine. Yes, we can send them home with a syringe driver, but there are some restrictions because the patient, we need to educate the family how to make use of opioids. And also there are some concerns when we send the patient home on opioids, especially intravenous opioids. So, as some of you have suggested, yes, we'll convert the intravenous morphine to oral morphine. So as I have already said, the 4.5 milligram of intravenous morphine has given the patient satisfactory pain relief. So how do we do the conversion to oral? Usually after the morphine IV titration, 1:1 conversion is what is done. So for a patient who had satisfactory pain relief with 4.5 milligram of intravenous morphine, we convert the patient or we send the patient back on 5 milligram of oral morphine. So the patient can be prescribed 5 milligram oral morphine every 4 hourly and double dose 10 milligram at night and an SOS dose of 5 milligram. So that is tab morphine 5 milligram Q4H, 10 milligram at bedtime or HS dose and 5 milligram SOS. So at night, we usually prescribe double dose. This is because it would not be convenient for the patient to get up after 4 hours and take the medication again. So usually at night, we prescribe double dose. Sorry, Binisha.
Please repeat.
Binisha, can you please unmute and ask me what you want me to repeat? Is the morphine dose or the conversion pattern you want to know? So, yeah. Yes, Binisha. What you exactly want me to repeat?
Ma'am, that conversion method, ma'am, morphine conversion method.
Okay. Yeah, sure. So, after intravenous morphine titration, when we do the oral conversion, it is 1:1 conversion. Suppose the patient had adequate satisfactory pain relief in 4.5 milligram of intravenous morphine, we convert it to 5 milligram of oral morphine. So that is because the tablet available is oral morphine tablets are available as 10 milligram, 20 milligram, 50 milligram tablets are available. So 1:1 conversion ratio, that is 4.5 milligram of intravenous morphine, it is converted as 5 milligram of oral morphine every 4 hourly and double dose at night, and the same dose is given as the SOS dose. Hope it is clear now.
Stella is asked about
understanding
why a double dose is used.
Yeah, that is for convenience that we prescribe a double dose. Many of you might already be knowing that compliance is a serious issue when we prescribe medications. Even we are very reluctant to follow the medications as per prescription. So expecting a patient to get up at night and taking a dose around 2 p.m. and in 2 a.m. I don't think that is practical, and that should be done, disturbing the patient from the sleep. to take the medication. So what we do is, to cover the night fully, we give double dose at night, so that the patient has satisfactory pain relief till he wakes up at 6 a.m. So usually when morphine is prescribed, it is given the first dose is given either when the patient wakes up or at 6 a.m. The second dose at 10 a.m., then 2 p.m., then 6 p.m. and double dose, it can be either at the bedtime or 10 p.m. So that is how it is being prescribed. So suppose the patient has, so now this patient has come to our inpatient unit. Suppose the patient has come to a setting where we don't have access to the, suppose the patient has come to a place where we don't have access to intravenous morphine. Then what will we do? So if the patient is coming to a setting or in where we don't have access to intravenous morphine, we go with oral morphine titration. So in such patients who are new to opioid, we usually start with 5 milligram of oral morphine, where the pain is severe, when the patient has moderate to severe pain, and we are planning to start them on opioids, we start with 5 milligram of oral morphine. That is 5 milligram every 4 hourly and 10 milligram at night, and SOS 5 milligram. Suppose the patient is already on weak opioids, then we start usually with 10 milligram. That is what the literature says. But usually we might not need 10 milligram. Usually in our practice, we do start with 5 milligram itself. And then depending upon the response to the pain, we titrate the dose. Now, moving on to a patient scenario. So we have already started, Mr. X was started on 5 milligram of 4 hourly morphine with 5 milligram SOS dose. So the patient whom we have done the IV titration, he has been converted to oral morphine, 5 milligram Q4H and sent home. He had adequate pain relief for 2 weeks. But since the last 4 days, he needed 3 SOS doses of morphine per day. What shall we do now? Can somebody give me suggestions? How can we move about in this? Because he was having adequate pain relief for the initial 2 weeks, but since 4 weeks, he's making use of SOS dose of morphine. Yes, thank you, Judy, for that. Yes, we can increase the dose of morphine. How can we increase the dose of morphine? So, when 2 or more than 2 rescue doses are taken, increase the dose by 30 to 50% every 24 hours. So suppose the patient has taken 2 or more rescue doses, then we usually increase the dose by 30 to 50%. So for this patient, he was on 5 milligram of oral morphine 4th hourly. We can increase the dose either to 7.5 milligram 4 hourly or to 10 milligram 4 hourly. So his dosing will be somewhere between 7.5 to 10. So some people, as I have already mentioned, it is a 10 milligram tablet. So they find it difficult to break the tablets, and they might prefer on 10 milligram tablet. But there also what we have to look into is we have to monitor them closely and see if there is any toxic effects. We'll be talking in detail about that later in this session. So how frequently, so I've already mentioned that we are giving them SOS dose also. How frequently would you give SOS dose of oral morphine and why? Any suggestions for that?
For breakthrough pain,
Yeah.
2 to 3 doses. When patient get pain,
Yes. Thank you. Thank you for all the responses. So, the patient, so we are, how frequently we are giving the SOS dose depends upon the time taken for morphine to peak its action in our body. So, the morphine takes around 60 minutes, like in the morphine, once the onset of action occurs in 30 minutes of oral morphine takes place in 30 minutes, and the peak action occurs within 60 minutes. So usually when we give SOS dose of morphine, at least 1 hour gap should be there between two SOS doses of morphine, so that the dose that is given can bring its maximum peak analgesic effect, which is when morphine is given orally, it is 60 minutes or 1 hour. So usually the SOS dose of morphine is given 1 hour. So now, morphine is a most important opium. So morphine, it is a naturally occurring opioid that is extracted from the opium Papaver somniferum. So morphine is usually extracted from this poppy plant, and this plant is grown mainly in 3 states of India, that is UP, Madhya Pradesh and Rajasthan. Moving on to the pharmacokinetics of morphine regarding the absorption, distribution, metabolism and excretion of morphine. We'll be dealing one by one. So absorption of morphine, it's a weak base, and some of it is absorbed in the upper part of the small bowel, and it is hydrophilic in nature, and hence the action is slow in onset but has longer duration of action. So sublingual, the absorption is very low for morphine, and even for buccal and gingival also, the research shows that the absorption rate is very low and it has a bitter taste. So if somebody says that they have adequate pain relief on sublingual morphine, we should believe that mostly it could be due to the oral. The patient might have swallowed that medicine, swallowed morphine, and could be due to the systemic absorption of the medication that resulted in the pain relief. So moving on to the metabolism, first pass hepatic metabolism. Once the oral morphine is swallowed, it reaches the GIT and gastrointestinal tract and then gets absorbed into the blood vessels, and through the portal vein, it reaches the liver. In the liver, morphine gets metabolized. So 90% of the morphine gets converted into its metabolites. And this metabolites are released into the systemic circulation. So, as I said, metabolism of morphine mainly takes place in the liver, and a minor part happens in the GIT and kidney. So 90% of metabolites, morphine gets converted to its metabolites, and 45 to 55% of the metabolite is morphine 3-glucuronide. So in the liver, morphine gets undergoes the process of glucuronidation, and it gets converted to morphine 3-glucuronide and morphine 6-glucuronide. 45 to 55% of the metabolite is morphine 3-glucuronide, which is responsible for the neurotoxic effect of morphine. Only 5 to 10% of is morphine 6-glucuronide, and which is primarily responsible for the analgesic effect. So, as I mentioned, this morphine, the majority of the oral morphine gets metabolized undergoes metabolism in the liver and gets converted to its active metabolites, which are responsible for its analgesic action. So that is why we say when the oral morphine dose is given, that it takes around 1 hour for this process to happen. So the peak analgesic action of morphine will occur only after 60 minutes of the oral intake of morphine. So there should be a gap of at least 1 hour between the SOS doses of morphine. So we are going back to the story that we were talking about. So the patient, Mr. X, who we have already started him on 10 milligram of oral morphine every 4 hourly. But now what happened is that he finds it difficult to take it every 4 hourly. So he was asking us for reducing the frequency. What will we do now? Do you have any suggestions how to reduce the frequency of this medication? Q6 hourly? Thank you, Maria, for that response. Yes, we can.
At night, double dose and 6 early.
So, yes, as Maria has suggested, we can go for sustained release of morphine. So the sustained morphine, it has 12 hours of duration of action. So the patient whom we have started already on 10 milligram of Q4H of morphine, that means the total morphine dose in 24 hours is 60 milligram. So he can be started on 30 milligram twice daily of sustained release preparation of morphine. So thus we can reduce the frequency of morphine. So moving on to the different preparations of morphine. Morphine is available as aqueous solutions, syrup forms, immediate release as well as controlled release tablets are available, capsules are available, and also as injections are available. So 1 ml contains 15 milligram of morphine. So now going back to the story. So we have the patient whom we have started on 10 milligram, Mr. X, was started on 10 milligram of morphine every 4 hourly. For the past 6 months, he was having adequate, satisfactory pain relief. But now he was brought to you with excessive drowsiness. And on examination, it was found that his serum creatinine was 5 milligram per deciliter. Will you do anything to morphine dosage? So now he has presented with extreme excessive drowsiness. So what can we do?
Reduce the dose. Any other answers?
So when you suggest reduce the dose, now the next question is why should we reduce the dose? So that brings us, so we have already discussed about the absorption of morphine. We have talked about the metabolism. Now moving on to the excretion of morphine. So morphine is mainly excreted by kidney by glomerular filtration. So what happens in renal failure is that we have already mentioned that the metabolism of morphine takes place in the liver and the morphine gets converted to its metabolites morphine 6-glucuronide and morphine 3-glucuronide. So in renal failure, what happens is that this morphine 6-glucuronide gets accumulated in the blood and the clearance is decreased. And so the half-life will be prolonged. So what happens? So more dose will be available for the analgesic effect, which is resulting in the toxicity of the toxic effects in patient. So what should be done? We should increase the spacing between the medications and between the doses and keep the dose either thrice daily or reduce the dose. Or we can also go for other alternate opioids which are more preferable in patients with renal issues. Renally safe opioids can be another choice. So now, Mr. X was sent home and is now taking morphine 5 milligrams. So we have, because of his renal failure issues, we have reduced the frequency of oral morphine to 8 hourly. So now he is on tab morphine 5 milligram 8 hourly. What happened is that the disease was progressing in him and he is becoming terminal. So after 2 months, he was unable to swallow anything, including morphine. Now, what can we do for him for his pain relief? He wants to be at home also and is unable to swallow.
Morphine and
Patches. Unfortunately, we don't have patches of morphine available. Yes, get him admitted and start IV dose injection. So suppose the patient wants to continue at home, we have other options also. We have another option. So that brings us to the routes of administering morphine. So the different routes by which morphine can be administered. The most preferred route of administration for morphine is orally. Orally, morphine can be given. Then intravenous or subcutaneous and per rectally and epidural and intrathecally morphine can be given. So these are the different routes of administering morphine. So now anybody has any suggestion on how can we proceed on the patient that we discussed earlier? So he was sent home and is now taking morphine 5 milligram 8 hourly, but he wants to be at home but unable to swallow anything. What can we do for him? Yes, Vinisha. Thank you for that. So he can be given rectal morphine. So 5 milligram of morphine 8 hourly, this immediate release tablet can be given per rectally. So this per rectal tablet is as effective as the oral tablets. So this is another option that we need to keep in mind when our patients are falling sick and unable to tolerate oral medication. So now we are moving on to another story. Mrs. K, a 55-year-old lady with carcinoma of colon, has abdominal pain which is continuous in nature. She was started on 10 milligram of morphine 4 hourly and she doesn't require any SOS dose of morphine as her pain is well controlled. Now the doctor has asked them to replace the morphine with 25 microgram of fentanyl patch. Next day, the patient report to you telling that they replaced the fentanyl patch after 5 hours as she had no pain relief. What will you do? Any suggestions? So this is opioid switching. The patient was on oral morphine and was having well-controlled pain. So the doctor has asked them to use fentanyl patch of 25 microgram. But after 5 hours, since the patient did not have any pain relief, the patient removed it.
Breakthrough oral night dose.
Okay, thank you. Thank you for the response. So we'll be talking about the transdermal fentanyl patch. So how this fentanyl patch acts is that it forms a subcutaneous depot of the drug. So once you apply this fentanyl patch on your skin, what happens is that it forms subcutaneously, it forms a deposition of this drug, and then this is slowly released into the blood. So this fentanyl patch, to produce an effective analgesia, it takes around 8 to 12 hours. Only after 8 to 12 hours, this patch will start producing the analgesic effect. So that is why the patient did not have any pain relief and before 5 hours, because they have removed the patch after 5 hours. So it takes around 8 to 12 hours for the patch to set its action. And usually this patch, when it is placed, it lasts for 3 days. And when you place a fentanyl patch, the skin condition, we have to clearly monitor the skin, make sure that the skin is intact and there are no bruises and abrasions, because that will affect the absorption of the drug. Similarly, the temperature can also affect the absorption. So the patient should be advised while keeping the patch not to pour warm water, because as a change in temperature can affect the absorption. And very important point to keep in mind is that fentanyl is not patch is not suitable for patients with unstable pain. So only patients with well-controlled stable pain can have relief on transdermal fentanyl patch. So now moving on to the different preparations of fentanyl. Fentanyl is available as injections, transdermal patch, also oral transmucosal fentanyl citrate. That is the form of lollipop. It is lipophilic, 100 to 150 times more potent than morphine. And 60 milligram of oral morphine in 24 hours is equal to 25 microgram of fentanyl patch. So when I say 25 microgram fentanyl patch, it means that 25 microgram of fentanyl is released every hour. And this patch can last for, as I already mentioned, for 72 hours. That is 3 days. It can last for 3 days. And this 25 microgram of fentanyl patch is equivalent to 60 milligram of oral morphine in 24 hours. That is 10 milligram fourth hourly. A patient on 10 milligram fourth hourly with stable pain, you can, if the patient is having controlled pain, you can convert him to 25 microgram of fentanyl patch. But the issue is that these fentanyl patches are a bit expensive. So now moving on to another patient story. So we have Mr. P, a 70-year-old man with a carcinoma of the lung and is complaining of throbbing pain on the right front of the chest, continuous in nature, 5/10 is score. He is a non-epileptic and he is on levetiracetam 500 milligram twice daily. How will you manage his pain? Any suggestions? So it's already mentioned that depending upon the intensity of the pain, severity of the pain score is 5/10. So as per the analgesic ladder, WHO analgesic ladder, adjuvant start. So as per the analgesic ladder, he would be prescribed on step 2 opioids because it is mild to moderate pain, 5/10. So tramadol would be the drug of choice. But since the patient is a non-epileptic and is already on anti-epileptic drugs and tramadol reduces the seizure threshold, we go by low dose of morphine. So in this patient, we don't prescribe tramadol because as it reduces the seizure threshold and there are chances of seizures, so we go by the low dose of morphine, 2.5 milligram of morphine. So now moving on to what are opioids. So opioids are generally a group of drugs which can be either be naturally occurring or semi-synthetic or synthetic drugs, which usually combines with the opioid receptors to produce their effect. And their action is antagonized by naloxone. And the receptors of opioids are mu, kappa, and delta. And sigma. Sigma is not a true opioid receptor because its action is not reversed by naloxone. So, classification based on the receptor interaction, opioids can be classified as agonist, antagonist, and agonist-antagonist. When I say agonist, it means that they act on the receptors and increases their action. When we say an antagonist, so in the presence of an agonist drug, what the antagonist does is that it reverses the action of the agonist. And an agonist-antagonist, they have agonist action on some receptors and they reverses the action on some receptors. That is agonist-antagonist. So examples of agonist are morphine. So antagonist, naloxone, naltrexone are antagonist, and agonist-antagonist is pendazoxine. So this is, so the difference between this graph indicates that as the dose increases, if it is an agonist drug, as the dose increases, the pain relief also increases. So this means that there is no ceiling effect. So as you keep on increasing the dose, the pain relief also increases. That is agonist. But in the case of agonist antagonist, what happens is that as you keep on increasing the dose, the pain relief also improves. But at a certain point, after that, even if you increases the dose, the pain relief will not improve. So that means that there is a ceiling effect. So agonist antagonist has got a ceiling effect, whereas agonist do not have ceiling effect. So what are the side effects? So side effects are usually the adverse effects that happens with the therapeutic dose of the medication. So even with the therapeutic dose of the medication, we have certain side effects. So you have already mentioned some of them. Constipation is the most common side effect that occurs with the morphine. Then nausea, vomiting, sleepiness, tiredness, itching, dry mouth, urinary hesitancy. These are the other side effects that can occur with the therapeutic dose of the opioid. So around 95% of the patients are found to have constipation, and this is one symptom that will last as long as the patient is on the opioid. So we'll have to regularly prescribe a stimulant laxative along with the opioid. So vomiting and nausea, usually it is a self-limiting symptom that occurs in 1/3 of the patients and that lasts for the first few days. Usually this is due to the stimulation of the chemoreceptor trigger zone, and we prescribe metoclopramide, haloperidol or domperidone for management of nausea and vomiting. Another side effect that we come across is sleepiness and tiredness, which is also a self-limiting symptom. So those were the side effects. Now the adverse effect that occurs when dose is administered higher than that is needed for the pain relief, or when the pain has poor response. Suppose the patient is given medicines in doses that is more than needed for the pain relief, then it will result in toxic effects. And the common toxic effects of morphine are delirium, myoclonus, and drowsiness. So in the chat also there were questions like opioids produces respiratory depression. Does opioid produce respiratory depression? So, yes. Yes. Okay. So usually when opioids are prescribed, orally, and by close monitoring of the toxic symptoms, they are very unlikely to produce respiratory depression. Except in case where this occurs due to some other this respiratory compromise usually occurs due to some other alternative reasons like pneumonia, pulmonary embolism, or cardiomyopathy, or maybe the patient is on some sedative medications like benzodiazepines. Otherwise, the morphine alone is very less likely to produce respiratory depression. This is because we do oral titration of the medication very cautiously, monitoring the toxic effects of the medication. And since we are doing it cautiously, monitoring all the toxic effects, it is very unlikely or less likely to produce respiratory depression. So, does opioid causes addiction? What do you think? Yes? No? Yes? So majority goes with yes. Okay, we have no's. Okay. So as per the research, when opioids are used for medical use, medical purposes, or medically when prescribed, substance abuse is very low. So through medical prescriptions are very less likely to produce substance abuse. And research also shows that there is a confusion between physical dependence and psychological dependence or addiction. And some people overestimate the risk of addiction. They are very afraid that this will result in addiction in patients. So these are some research findings that I'm eliciting. So what is addiction or psychological dependence? So addiction, it is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. So that is the definition. So impaired control over the drug use, compulsive use, continued use despite harm and craving. So that is addiction or psychological dependence. So let me ask you something. How many of you drink coffee? Like morning without coffee, this is not going to happen. So suppose you don't get coffee for a day. What will happen? Yeah, so many are drinking coffee in the morning. Suppose one day, okay, headache. One day morning you found that you forgot to get the coffee powder and the coffee powder with you has finished. So, okay, it's okay. Headache, feel sleepy, okay. Feels lazy, if not feels lazy, okay. Is this addiction? What do you think? Is this addiction? Could be. Yes. Could be, of course. Okay. Yes. Suppose you realize that you don't have coffee powder at home, but you know that your neighbor has got the coffee powder with them. You break open their house and get the coffee powder from them and try to prepare coffee. That is addiction. So what is this? Because you had headache. So that is withdrawal syndrome or physical dependence. So it is a state of adaptation that is manifested by a drug class specific. So that is, since your body is used to this since long, your body wants it. So they are it is showing signs of withdrawal like headache, laziness, sleepy, all this. That is physical dependence. Addiction means you know that is wrong. You shouldn't be doing it. Despite knowing that, you try to break open the house and get the coffee powder from there. That is addiction or psychological dependence. This would be the simple way of identifying or distinguishing the both. Okay. So a patient on 5 milligram of oral morphine 4 hourly, that is 5 milligram of oral morphine 4 hourly is total 30 milligram of morphine in 24 hours. The cost of which is around 3.3 rupees 50 paise. Suppose the patient is on tramadol, which is the equipotent dose of tramadol is, so morphine is 1/10 of tramadol. So 300 milli, that patient might need 300 milligram of tramadol for pain relief, satisfactory pain relief. And the cost of that is 24 to 50 rupees. The same patient, if he is on fentanyl patch, as we have already discussed, the patient, if the total dose is 60 milligram, the equivalent dose of fentanyl would be 25 microgram. So now this patient is on 30 milligram of oral morphine. So the equivalent dose is 12.5 microgram, which would cost around 250 to 400 rupees per day. And if the patient is on 5 milligram of methadone, which will cost only 4.4 rupees 50 paise. This is just to give you an idea about the different prices of the opioids, so that understanding the socioeconomic status of the patient, you can prescribe the opioids. That brings us to the end of the session. Yeah, we can discuss the questions in the chat if you want, or if somebody wants to ask something, you can unmute yourself and ask.
So Jyoti is asking how much morphine how much morphine dose we can use at a time?
So, as I've already mentioned, morphine is an agonist drug. Morphine does not have a ceiling effect. So, there is no definite dose, how much dose of morphine. So, what you need to monitor is the toxic effects. Depending upon the pain of the patient, you can slowly tighter the morphine dose, monitoring the toxic effects.
So next question is, can you explain the slide on antagonist?
Okay. Give me a second. So there, depending upon the receptor interaction, the opioids are being classified as agonist, antagonist, and agonist-antagonist. So a drug is an agonist drug when it acts on the receptors and produce its effect. But then a drug, in presence of an agonist drug, that reverses the action of the agonist drug, it is called an antagonist. So what happens is that morphine is an agonist drug. So it produces adequate pain relief. But when an antagonist of morphine is naloxone, so when you add naloxone to it, this naloxone will replaces the morphine from the receptor site and it will reverse the action of morphine. So what happens is that if the patient is on pain, morphine will be acting to relieve the pain, but what happens when you add naloxone, it will replace the morphine and this naloxone will act on the receptor sites and the patient will be having increased pain. So that is the action of antagonist. And an agonist antagonist drug means this drug will have on some receptors mu. So we have different receptors mu, kappa and delta. On some receptors they will have agonistic action and on some receptors they will have antagonistic action. Pendoxazine is another drug which falls under the class of agonist antagonist. I hope it's clear.
Okay.
Yeah.
Yes.
Okay, Maria. Do we have any other questions?
Partial agonist. Please do click on partial agonist.
So this agonist antagonist, so that is moving into the detail, you will get confused. So I didn't want to explain on that. So this agonist antagonist group of drugs can again be classified as they have some partial agonistic action and some of them have mixed agonist and antagonist action. So they will be partially having an agonistic action. So that is another classification that comes under the agonist antagonist. Group of drugs are again classified as partial agonist and mixed agonist antagonist.
Any other questions? Yeah, can you stop share and can you get back the chat? So I think one question is there. Previous back. Okay. So Ashwati was put a question in the chat. Ma'am, is there any chance of respiratory distress at night? Could you please repeat that we don't understand? If we give double dose at night, is there any respiratory distress? Is that you mean? Yes.
So Ashwati, as I've already mentioned, though we study in our literature that the morphine can cause or opioids can cause respiratory depression. As I mentioned already, when we prescribe doses the orally, when it is closely monitored and titrated properly or cautiously, very less likely to produce respiratory depression. So even the double dose at night will not cause respiratory depression because it is only depending upon the pain, intensity of the pain that we are titrating the dose and also we are monitoring the toxicities. So it is very less likely to produce respiratory depression.
So and also if you give double dose at night, what is happening in our bloodstream, so that opioid level little bit high, but gradually it will comes down. When if the opioid level is high in the blood stream, so that time the patients will feel like sleepiness. So anyway, they are going to sleep. They will get good sleep, but gradually the opioid level is comes down. The early morning, they will be free out of that side effects. Definitely, there will not have any sleepiness or drowsiness. So our idea behind that is, if you give double dose, the patient will not get they no need to get up in between the night. So it will be affecting their sleep. So that is why we give double dose at night. So only thing, the opioid level in the blood little bit high that time. So that will gradually comes down. So, but there could be chance of fall patients gets up. So, Sister Maria, from my 20 years of experience, I didn't see any patient with these kind of problems. So usually we have given double doses at night. So at least even one patient I didn't see anyway in the regional cancer center and also here. So you can give double dose. No worry about that.
So the risk of fall, as Sheba has already said, there is risk of fall with even with benzodiazepines if we prescribe. If we don't monitor the patient properly, there are risk of fall. So, but I don't think, as she has already told, we never had such an experience. But I would say, if you ask the patient to get up at night and take the 2 a.m. dose, that would be more difficult for them.
Any other questions? Okay, we can move on to the patient story. In the meantime, if you have any questions, please put it in the chat box. We will discuss it later. So, Ms. Jyoti will be presenting a patient story. Jyoti, over to you.
Yes, ma'am. Good afternoon, ma'am. My patient age is 35 years. Is it audible, ma'am?
Yes, you are.
Okay. Patient details. Age is 35 years, gender female, and diagnosis is CA rectum with peritoneal metastasis. Presenting complaints are patient is having lower backache, vaginal itching, ascites, discomfort, nausea and vomiting, with that abdominal pain, weakness, weight loss, and difficulty in breathing. Pain score is 6 to 8, and whenever she moves or does any activity, that time pain increases up to 10. So PQRST of pain is P, movement and activity. Quality of pain is sharp and stabbing pain. Then region starts from lower abdomen and headed to chest and neck. Then abdominal pain score is 6 to 8, and the time of pain is continuous, sometimes increases whenever she does any small activity. History of illness. Patient had history of pain and constipation since 3 years. Gradually, pain increased and sphincterectomy has been done on 10/1/2020, as they came to know from a local physician that the patient is having piles. So they had done sphincterectomy. Then recurrent pain occurred and cancer diagnosis has been done. For cancer diagnosis, 28 chemotherapy and 28 radiation has been done for the patient, but after that CA diagnosis, surgery is refused, and peritoneal tapping is done at least 4 to 5 times. Then examination, patient is conscious and oriented. sometimes anxious. Body weight is 38 kg as weight is decreasing day by day. Vital signs: BP 110 by 70 mm of Hg. Temperature is 98 Fahrenheit. Pulse 119 per minute. SpO2 is 96% and respiration is 26 per minute. Treatment and significant investigation. HB is 9.2 gram. Peg has been done for the patient on 4/5/23. Shows rectovaginal fistula and peritoneal nets. Sigmoidoscopy has been done on 18/3/23. Shows bulge in vulva. 28 chemotherapy and 28 radiation has been done. Psychological aspects. 35-year-old married woman lives with her husband and 2 children in their own house. She is a housewife and her husband is farmer. Monthly income is nearly 10,000 and husband is a breadwinner of the family. A strong woman who believes in God and husband is having strong religious belief. Because of this, they went to some religious Baba and had some jadi booty kind of medications, but no any changes occurred in the general condition of patient. Because of pain and discomfort, patient is having lot of psychological issues. She says always, like, the pain is how much I cannot even bear the pain. So once I die, that pain will go with me. So I want to die as soon as possible. And sometimes to relative also, she says, you make me die anyhow. I don't want to stay now. Medications, tablet morphine 40 mg 4 hourly is going on. Then Dulcolax 10 mg HS, PAN 40 mg OD, injection Perinom SOS and injection Midas SOS. Main concern is pain reducing of the patient, as patient is having more severe pain whenever she moves or whenever she even wakes up from the bed to have some water or to drink some juices or to eat. That time also she will have pain. Then second concern is reducing her vomiting and discomfort. Then religious belief of the family. Summary: 35-year-old female with carcinoma of rectum with peritoneal mets presents with ascites and severe pain. Peritoneal tapping has been done and surgery refused by the patient. Chemo and radiation done and palliative care is on for the patient. Discussion point. Already I have discussed these points in our palliative center also. But still I want to discuss this. What should be done for the patient and the family, and other measures if we can find to reduce pain and discomfort of the patient. Thank you.
Thank you, Jyoti, for the wonderful patient story. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So I think this presentation is clear to everyone. We can move on to the discussion points. Her first question is, what should be done for the patient and the family? So we would like to expect your suggestions. Please give some suggestions to Sister Jyoti. So she needs to help this patient. Go back to the summary. So just imagine a 35-year-old female with carcinoma of rectum with peritoneal mets. Rectovaginal fistula is there. Ascites and severe pain. She is on morphine. So she was refused to her surgery, but she had taken chemotherapy and radiation. Now she is on palliative care department. So In your department, you just assume in your department this patient is there. So what all you have done for these patients, especially for patient and his and her family, what all things you will suggest? Psychological support, very good. Counseling both patient and family. Sister Jodi, did, does she know the prognosis?
Yes, ma'am. She knows the prognosis.
Prognosis, diagnosis and prognosis, right?
Yes, ma'am. Yes, she knows.
What about the family?
All the family members also knows. Actually, family members has accepted the current situation that going to be worsened day by day. But
Okay.
the thing is, patient is not able to bear the pain. She asks always, I should die because I can't handle this pain.
Okay.
Anytime pain occurs, even I can't go to washrooms, I can't wake up, I can't do any movements. If I do turn also, so the pain increases suddenly.
Okay. Do you think this morphine, you have mentioned on morphine, this patient is on morphine 40 milligram 4 hourly.
Yes,
Do you think that morphine give some kind of pain relief, or the morphine is not giving?
uh, yes, ma'am. Morphine is giving lot of pain relief to her.
How
But
much? How many hours on if she take one morphine, 140 milligram morphine, one dose
yes,
at a
ma'am.
time? So how many hours the pain relief is lasting?
Nearly she gets like 2 to 3 hours. Then before the next dose, before that only her pain starts.
So every 4 hourly you have given, no? So if
Yes,
she
ma'am.
take,
Even
yeah,
early morning, 2 o'clock, yeah, we are also that also we are giving.
okay, if she take a dose 40 milligram morphine at 2 a.m. the morning, so that time the patients will get, I understand that 3, 4, 5 till 5 o'clock, the patients will get adequate pain relief, right?
Yes, ma'am.
Okay, only 1 hour the patient is in pain.
Yes, ma'am. Yes, ma'am.
Okay, so what
In
shall
that
we do?
also, that is a severe pain.
What shall we
Sometimes,
do for that? What is the problem? So we all please respond all.
that only I need, ma'am, because
Uh,
we
Jyoti,
sometimes SOS we gives her.
we understand. We understand.
Yes,
We
ma'am.
will ask others
Yes,
uh,
ma'am. Yes, ma'am.
what they will think. Please respond. Could we start morphine infusion? Okay, this patient is in home only. No infusion syringe pump, no syringe driver is available. So only oral morphine is the possibility there. You can just imagine, or you have only morphine, oral morphine, but this patient is getting 3 hours pain relief after taking morphine. Only 1 hour the patient is with pain. That time it's a severe pain. SOS dose has to be gave. Okay.
Yes, Veena, you're thinking in the right angle.
Okay. Any other answers? It can be,
Yes, Vaijayanti. So what can be done? It can be end of dose pain. Okay. So Judy, can I understand a bit more about the patient's pain from you?
What you want to understand, ma'am? Like,
So I understood that as per what you have said already, I understood that the patient was having adequate pain relief for 3 hours.
yes, ma'am.
So are you giving her SOS dose of morphine?
Yes, ma'am. Breakthrough doses we are giving, and SOS doses are also we are giving.
How many doses per day?
She takes nearly 2 doses per day.
So, yeah. So what can be done if she is on SOS dose of morphine? What does that indicate? Is there any signs of toxicities?
No, ma'am.
No. So, as I understand from the patient's story, she is her main concern. She had a lot of concerns that has been elicited. Out of that, the main concern which she is not able to move forward is due to her pain, unbearable pain, and she wants to end her life. So, what can we do for that? We understood already that by the response of the patient that it is an opioid sensitive pain, and what, as per what you have said, the patient is not having any toxic effects. So what does that indicate? It clearly indicates that the patient is not on the adequate dose. We need to increase the dose. So
Okay.
depending, if the patient is already on 2 to 3 rescue doses, increase the dose of morphine by 30 to 50%.
Okay, ma'am.
So you can go for 50 mg 4th hourly.
Okay.
So why haven't you started her on 50? Is there any other concern?
What, ma'am?
Why the morphine dose was not escalated? Is there any concern regarding increasing the dose of morphine?
Actually, the concern is patient their own self. Patient don't want to eat medicines from 3 to 4 days.
Mm-hmm.
She tells, now you don't give these medicines or you reduce those medicines.
Yeah. So there we'll have to talk with the patient and understand her concerns and try to help. Tell her that we are with her to help her out and see what is more important to her. Being in pain or taking this medication, which is more important to her, we need to understand from her. She is
Okay, ma'am.
surely in pain and she needs analgesic support. And we have found the right medication also. Opioid, like morphine, is giving her pain relief. So I understand, Judy, this is really a difficult situation that you are going through in managing her. She's very young. Even the team might be finding it difficult to help the family
Yes,
move forward. But one of the
yes,
things
ma'am.
that you can focus on would be to communicating her that she can be pain-free. You cannot cure her disease. You cannot, but you can give her symptomatic relief. So as long as she is there, you can give her better symptom relief.
Okay.
And for that, she also has to help us understand and take the medications properly. So
Yes,
regarding
ma'am.
the yes,
Thing is,
yeah.
whenever we go to her or we try to communicate with her, for that also she refuses. She tells, if I'm communicating with you also, that pain increases. So she directly tells her that, please sister, please doctor, please ma'am, don't talk to me. If I'm talking also, my pain is increasing.
Mm-hmm. It is a difficult situation, Jyoti. I can understand that. But keep trying because at least maybe there is one person in the team whom she finds very comfortable with, who can communicate with her and give her the message that this will help her and relieve her and keep her comfortable.
Yes, ma'am. That one person is there already in our team that goes daily to her at least nearly 3 times she goes to her and she talks nicely. But same things she tells to her.
Mm-hmm.
So still we are going on this thing only that we have to make her more communicate that we can know what is the main concern for her.
Jyoti, where is she right now? Is in the hospital or home?
Yes, ma'am. She is in the hospital only.
So then, do you have injection morphine?
No, ma'am. In ours, like our department, we are not having IV morphines.
Okay.
You can go for per-rectal preparations also, Jyotish.
What, ma'am?
Per-rectal preparations also, but
Okay,
if,
ma'am.
but I don't know whether because she has got a fistula there, she has
Yes,
got a
ma'am. The
vaginal
thing
fist-
is,
Yeah, Judy, you're muted. You're trying to
yes,
say
ma'am.
something?
Yes, ma'am. Actually, we tried for her glycerin suppositories when she was having constipation, but she is having hemorrhoids also, and fistula is also present.
So, regarding her prescription, I would suggest to continue her on a non-opioid also round the clock. Optimize the dose of like paracetamol. I doubt you might have tried and she is hesitant to take medications. I don't know. Otherwise, it would be a paracetamol 750 milligrams 6 hourly would be a
Okay.
good coverage to her pain. And also the laxatives, I would suggest adding a stool softener also. So as
Okay.
all of you are aware, one of the most common or the most common complication or side effect with morphine is constipation.
Constipation.
Yeah, and as long as the patient is on the opioid, this is because the morphine acts on the gastrointestinal tract and it reduces the peristalsis. So that
Yes,
is why
actually, laxatives are going on, ma'am.
but I think the dose might not. I'm not sure how
Okay,
is
ma'am.
her bowels now.
Yeah, bowel pattern is good only.
Okay, okay.
So, Jyoti, so as Amrita madam was saying, like increase the dose. You have to talk to the, if possible, you can talk to the husband
Yes,
and
ma'am. Yes, ma'am.
give a continuous dose, regular dose of morphine, and you can increase the dose. So, as we
Yes, ma'am.
discussed earlier, on immediate release morphine has around 3 to 4 hours, giving 3 to 4 hours pain relief only. That one dose will be able to give him 3 to 4 hours pain relief. So after
Okay.
that, the pain will back. So
Yes,
when we take on morphine, that opioid level in the blood little bit high. That time the patients will get adequate pain relief. That gradually the opioid levels will comes down. That time the patients will experiencing pain, no, so that is why the after 3 hours the patients again experiencing pain. So that means that as ma'am said earlier, this dose is not adequate. Okay,
Okay.
definitely we need to increase the dose. 30 to 50% we can increase. So
Yes, ma'am.
now I think you can increase the dose of now the patient is on 40 milligram. You can just increase 50 milligram and see. Okay, and the other side you have to look into the toxic effects. So if the patient is not having any toxic effect, definitely you can increase the dose. The one thing
Okay.
you have to check whether the opioid is responding to her pain or not. So if definitely from your report we understand that this patient is having the pain which is opioid is effective. So that is one thing you can increase the dose. So
Yes,
and
ma'am.
the another thing,
Definitely.
whenever you have prescribed morphine, so maybe on doctor is prescribed morphine every 4 hourly. The instructions which you have given to the patient and caregiver is very important. So
Yes, ma'am.
they didn't know they what medication. So definitely they will know if you give some medications for their pain, they know okay this is for their pain. So we are the persons to tell them clearly what the medication, so what how the medication is work, and what are the side effects, what in between the patient's pain comes. So how do they take breakthrough dose, that all things you have to tell them. So the first and most important things you have to tell the patient and caregiver is this is for your pain, not others. This medication is prescribed by the doctors for your pain. You have to take it every 4 hourly. So this particular medication has that only 3 to 4 hours that only thing. So that particular dose is giving pain relief every 4 hours only. For 3 to 4 hours only, the particular dose will give the pain relief. So that's why they have to take every 4 hourly. That's the first point you have to tell the patient and caregivers. And the another thing is breakthrough dose. So after 1 hour, so if they take one morphine, they have to wait at least 1 hour. So after that, if they are not getting adequate pain relief, they have to take an extra dose. So the extra dose will be the same dose of the regular dose. So that also we have to tell. And also you have to tell the double dose at night. They have to take double dose at night. Otherwise, they have to get up in between the night so that sleep will be disturbed. And another important point, side effects. So as ma'am was mentioned earlier, constipation is the most common side effect. So they should take Dalcolax Bisacodyl 5 milligram 2 HS at night every day. So that is must. And another thing, so initially this is a new drug for them. So they might be developing nausea and vomiting. So you have to give tab metoclopramide 10 milligram for TID, that 3-time dose. So that will be self-limiting. After 3 days, most probably that vomiting tendency will subside. And another thing is tiredness will be there. Tiredness or sleepiness will be there in the initial days, but that is also self-limiting. So that will be gradually, that problem is also gradually subside. And the toxic effect part, so if there is a toxic effect, the drowsiness, delirium, or that myoclonus there, they definitely they have to report us. Okay, if they have a delirium there, you have to identify the cause, and you can give some medication for that. If there is extreme drowsiness there, then you can think about the reduction of dose. You have to maybe you can skip 1 or 2 dose and find whether that patient is get into normal, and then you can just think about to reduce the dose from maybe 30 to 50% you can reduce. So that way we can manage. Okay, so these all important things you have to tell the caregivers and patient about while we in that introducing morphine. And the another important thing, this is for your pain, not others. That is also very very important. If someone develop severe headache in their family, they maybe usually they will give one morphine. You can take, this is for pain, no, you can also take one morphine. So that kind of things will be there. So we have to avoid such things. You have to tell the caregivers and patient about this clearly. So
Yes, ma'am. Definitely, ma'am.
okay, is there any last minute questions? Time up, we can wind up. No questions. So I think we can wind up the session today. So definitely, Jyoti, so one more thing, you try to reduce your physical pain first, and then you can look into the other aspects also, psychosocial, spiritual, and that aspects also we have to look into. If they have
Yes,
a physical distress, definitely we have to reduce her physical distress first, and then only you can move on to the other parts. Definitely the total pain concepts we have to keep it in mind always whenever you have seen these kind of patients. So that is also important.
Yes, ma'am.
So thank you, Dr. Amirtha,
Thank you so
for
much,
the
ma'am.
wonderful session. Thank you, Jyoti, for the wonderful patient story presentation. Thank you others for their participation and contribution. Thank you.
Thank you, ma'am.
Thank
Thank you, Dr. Amirtha. It was really nice listening to your wonderful session. I believe it was very insightful for the participants as well. Thank you, every participant, for joining in. Please do remember to leave your valuable feedbacks because that helps us to improve ourselves. So, with the promise that the next session would be equally interesting and joined by another eminent faculty. This is Sri Priya along with Dr. Amirtha Thambi and Sister Shiva signing off from the Tipsy Cover. Till the next session, everyone take care, keep spreading happiness. Bye bye.
Thank you.